Hello, everyone. We apologize for the delay, but welcome to our session, The Effects of Modulator Therapies on Pregnancy and Reproductive Health. My name is Chelsea Stahl. I am a yoga teacher, a business owner, a home DIYer, and most relevant to today, I'm an adult with cystic fibrosis and gave birth to my beautiful baby boy Brewer 9 months ago while taking Trikafta. I live in the US Virgin Islands with my husband Connor and baby Brewer. We own a yoga studio and freediving school, captain boats, manage Airbnbs, and always try and find time to fit in a day at the beach with our little man in between. You will hear much more about my story later on, but I will be moderating today's session, and I'll be introducing our other speakers in just a moment. Before I do, I wanted to provide a few housekeeping items. I know you've heard this before, but this session is being recorded and will be available after the event on the CF Foundation's YouTube channel. You'll be notified by email when the session recordings are available. We'll be taking audience questions during the session. We encourage you to submit your questions at any time into the chat box. We won't be able to answer questions about individual diagnoses or treatment plans, but we encourage you to use the information you learned today to have a conversation with your care team. We will do our best to answer as many questions as possible. There are also going to be a few polling questions from our panelists, which will be prompted to answer throughout the session. These polling questions will give us an idea of who everyone in the audience is and what you're excited to learn about today. The polls can be found on the right side of your screen next to the Q&A and chat. You should see our first poll popping up somewhere on your screen right about now. Whenever a poll pops up, just take a quick moment to answer, and I will launch the results afterwards in a few minutes when we begin to speak about them. Well, with all of that out of the way, let's get started. So you can assume from the title, this session will be mainly focused on pregnancy and reproductive health in relation to modulator therapy, specifically Trikafta. This is amazing information for all members of the CF community, whether you're on Trikafta or not. But to ensure that this session stays 70 minutes and not 5 hours like it most likely could, we will be focusing mostly on individuals who are on or eligible for Trikafta. We will be touching briefly on male reproduction, pregnant individuals who do not have CF but are carrying a child with CF, and an exciting upcoming study about health outcomes of parents with CF. I feel like this is the time we should have some music come on of let's get it on, but I doubt the CF Foundation would like that. So instead, let's just jump right into it. We'll meet our first clinician, Dr. Andrea Roe. She's a gynecologist with a subspecialty in complex family planning at the University of Pennsylvania Perelman School of Medicine. Her research focuses on contraception, fertility, and gynecological care for females with complex medical conditions, such as cystic fibrosis. Welcome to the session, Andrea Roe.
Thank you so much, Chelsea. I hope everyone can hear me okay. I'm joining by audio only today. Welcome to everyone to this session. Looks like the poll results are coming in, and it seems like the biggest group of people here in the audience are people with CF. And it looks like there's also a group of parents with CF and then some other loved ones and other people as well. So welcome to all. If you can advance to my next slide and the next one after this. So I'm going to be talking about male and female fertility in CF today. And I'm going to, since I'm talking about fertility and infertility, I first wanted to share the medical definition of infertility, which is the inability to conceive after 12 months of regular sexual intercourse between a male and a female partner without any use of contraception. And for those over 35 years old, only 6 months of trying is required before infertility is officially diagnosed. Next slide, please. And so I'm going to begin with talking about fertility in males with CF. Next slide. So the vast majority of males with CF are born without a vas deferens, which is what transports the sperm from the testes to the urethra. And this means that even though sperm may be produced, there's no way for the sperm to get out of the body. And this is called obstructive azoospermia. And in addition to the congenital absence of the vas deferens, which is abbreviated to CBAVD, the epididymis, which is where sperm mature, and the seminal vesicles, which is where ejaculatory fluid is produced, those may be underdeveloped as well. Next slide. So as a result, if a male with CF gets a sperm analysis, there is no sperm in the ejaculate has low volume, and the pH is acidic because the fluid that the seminal vesicles normally produces has a higher pH. Next slide. So why does congenital absence of the vas deferens occur in CF? The thought is that, like so much in CF, the CFTR mutation is at the root of this issue. We think that the vas deferens exists early on in utero during fetal development, but the CFTR protein causes the vas deferens to clog with mucus, most likely, and then this tract actually degenerates before birth. And this hypothesis comes from evidence that second trimester fetuses with the CFTR mutation have been shown to have a vas deferens that is filled with secretions. Next slide, please. So the good news is that since males with CF do make sperm, there are procedures that can be performed in order to extract the sperm for use for reproduction. And the least invasive is biopsies and aspiration of sperm from the testes or the epididymis, like the PESA or the TESA. And slightly more invasive are the microsurgical or the open procedures like the MESA or the TESI. And these are typically performed by urologists. Next slide. Since the sperm are extracted without the usual fluid, the next step for reproduction is called intracytoplasmic sperm injection, or ICSI for short. And in this procedure, a single sperm is injected into an egg in basically a petri dish in order to form an embryo that can be later transferred and develop into a pregnancy. And in this way, IVF can help males with CF conceive their own biological children. Next slide. However, there are still some reproductive issues even once we bypass the vas deferens issue, again, likely related to the CFTR mutation. Compared to males who have CBAVD, who therefore need to undergo those same procedures we just reviewed, but who have CBAVD without CF, those with CF have a lower total sperm count. And you can see that in the left side of this graph compared to the right side of this graph. Next slide. In addition, compared to males who have CBAVD, but again, not CF, those with CF are more often needing a second sperm extraction procedure to obtain the sperm necessary for IVF. And also those with CF have lower fertilization rates. However, despite some of these extra hurdles, it seems that pregnancy and live birth rates are the same for males with CF and those with CBAVD without CF. Next slide. So infertility among males with CF is not just an anatomic issue of missing the vas deferens. It does seem that the CFTR mutation may impact spermatogenesis, or the actual development of sperm. And lab studies show that the CFTR protein relates to sperm motility and shape, and that inhibiting the CFTR protein reduces sperm's ability to fertilize eggs. And then in addition, testosterone deficiency occurs in 25 to 45% of males with CF. And this can affect libido, mood, and fertility, and may be another and separate contributor to this issue of fertility. And the treatment for this is testosterone replacement. And it's really recommended to go through a doctor who can perform the appropriate tests and make the correct diagnosis of low testosterone. Next slide. Currently, we don't know how modulators might affect male fertility. One of the audience questions that we received before today was about how modulators might improve fertility in males. And as of now, the answer is that we don't know exactly. For someone who does not currently have a vas deferens, modulators would not be able to bring back that physical structure. And so a sperm retrieval procedure and IVF would still be necessary. But it's possible that exposure to modulator therapy for a CF-affected fetus in utero could end up preserving the vas deferens. And it's plausible that modulators could affect sperm quality or testosterone levels and things other than the vas deferens in an adult. But research is really needed to study this further. Next slide. So now turning to fertility in females with CF. Next slide. Historically, females with CF had significantly lower pregnancy rates than in the general population. And the question was, were females with CF not trying to conceive as often, or were they trying at the same rates and not as successful at conceiving pregnancies? And the answer to this, it turns out, is really both. There was a study of about 600 females with CF across many different countries, and only 40% of females with CF had attempted to conceive a pregnancy. And this is lower than in females without CF. And then of that subgroup who tried to conceive, 35% experienced infertility, which is a significantly higher rate than the 10 to 15% infertility rate in the general population. Importantly, we should note that this study was done prior to widespread use of modulator therapy, so it's possible that these numbers are not quite true in the current day. Next slide. Over the last few years, there's been this huge increase in pregnancies in CF, in the CF population in the US, and numbers have doubled between 2019 and 2020. This timing coincided with the widespread uptake of Trikafta, which has led this community to draw a connection between modulator therapy and increased fertility. And this is the Trikafta baby boom that one of you submitted a question about. Next slide. There are data in humans to support this connection between modulator therapy and fertility, but it's mostly reports, reports of individual cases or case series. First, in clinical trials of ivacaftor, 2% of female participants in that study became pregnant spontaneously, including some who had reported extended periods of infertility prior. And then in a case series from 2 centers following the rollout of Trikafta in the fall of 2019, 7% of reproductive age CF patients in those centers became pregnant, again, including individuals with known infertility. And so while this doesn't prove the connection between Trikafta and fertility, one very compelling piece of data from this report was that the average time to conception in those who got pregnant was only 8 weeks after each individual started Trikafta. Next slide. So there are a number of possible etiologies of female infertility in CF, including malnutrition and chronic disease, which can suppress hormones in the brain that regulate ovulation and the menstrual cycle. There may also be pH alterations in the reproductive tract, although this is mostly theoretical and hasn't been studied well. Females with CF may have decreased ovarian reserve, which means that fewer eggs in the ovaries are available for conception and pregnancy. However, it's not really clear that this actually impacts the ability to conceive. And then finally, the CFTR protein in the cervix may cause cervical mucus to become thicker in the same way that respiratory mucus is thick in CF. Next slide. So there are some old case reports from the 1970s that show that females with CF had thick cervical mucus. In a typical cycle, cervical mucus becomes thin around the time of ovulation in order to allow sperm to enter the uterus and fertilize the egg. And you can imagine that if the mucus is dehydrated and thick, this could prevent fertilization and therefore pregnancy. Next slide. So our group at the University of Pennsylvania investigated cervical mucus among females with CF on Trikafta, as well as females with CF not on any modulator therapy and females without CF. We assessed cervical mucus just prior to ovulation when it should be at its thinnest and its stretchiest. And we used the World Health Organization's standardized scoring system, which assigns points to various characteristics of the cervical mucus. We ended up recruiting 11 females with CF on Trikafta, 10 without CF, but we did have difficulty recruiting people with CF not on any modulator, so we had only 2 participants in that arm. And what we found was that females with CF on Trikafta and females without CF had comparably high quality cervical mucus with mucus scores of 11.7 and 12.6 respectively out of a total of 15. And the 2 individuals not on any modulators had a mean mucus score of only 5, which was noticeably lower than the others. But this group size was really too small for us to draw any significant conclusions from. So this study shows that cervical mucus is really not likely to impede fertility in females with CF who are using Trikafta. And when you put this together with those older reports of thickened cervical mucus in CF, they kind of support the hypothesis that modulator therapy may improve cervical mucus. Next slide. In the past, it's been estimated that about a quarter of females with CF have attempted to conceive using assisted reproductive technologies, though it's likely that this fraction is decreasing these days. And I just wanted to briefly review what these treatment options look like. So first, if fertility issues are arising from a condition like malnutrition, one potential course of action is to correct that to the extent possible. We know that people who are underweight and may have anovulation can resume normal menstrual cycles once they regain a normal weight. Another option for anovulation is to use medications to reintroduce ovulation. And then other options include intrauterine insemination, IVF, surrogacy, and adoption. Next slide. In intrauterine insemination, or IUI, sperm is injected into the endometrial cavity, the uterine cavity, and the individual ovulates spontaneously or with the help of hormone triggers. And you can see how this could be helpful if the cervical mucus is thickened because it bypasses that barrier at the level of the cervix. Next slide. In IVF, the ovaries are stimulated to produce multiple eggs, which are retrieved and then fertilized by sperm in vitro. And the resulting embryo is then able to be put back during a subsequent menstrual cycle in the same individual or in another individual who's going to carry the pregnancy. Next slide. So one thing I wanted to emphasize is that pregnancy planning is really helpful in CF. There are general health benefits, including planning to start prenatal vitamins or changing behaviors to maximize health. Planning or early identification of a pregnancy also allows time for carrier screening or early genetic screening, which may be important. And then in CF in particular, pregnancy planning is very important because a high-risk OB consult can be obtained prior to pregnancy to review medications and discuss specific risks of CF and other issues as they relate to pregnancy. Planning also gives an opportunity for the individual to work with their CF team to optimize their health, including their pulmonary status and diabetes, for example. One study has shown that females with CF who had unplanned pregnancy experienced an increase in pulmonary exacerbations after pregnancy compared to pre-pregnancy, and this didn't occur for those with CF who had planned their pregnancies. Next slide. And finally, I just wanted to mention that while this talk has focused on fertility, not everyone wants to become pregnant, and certainly even those who wish to conceive still may spend many years preventing pregnancy. So I wanted to just quickly review this list of current contraceptive options that are on the market in the US. So the types that are most effective and are long-lasting are at the top, and these include the Nexplanon arm implant, the intrauterine device, of which there are two kinds, a copper kind and a hormonal kind. The upside of these is that they're extremely effective at preventing pregnancy, although they do require a small office procedure for insertion and removal. And then you can see on the right of the top row, permanent contraception or sterilization is also extremely effective, but requires a small operation and is irreversible. And the next contraceptive methods are in the second row, including Depo-Provera, which is an injection that lasts for 3 months, and then contraceptive pills, of which you take every day, the patch, which you wear in your body and switch every week, and then the ring, which goes inside the vagina and switches monthly. And then at the bottom, non-hormonal methods, which you use with each active intercourse and require consistent use to work well. Next slide, please. So, in conclusion, 95% of males with CF have absence of the vas deferens, and CFTR protein issues may also impact sperm quality. 35% of females with CF who try to conceive have infertility, and the causes of infertility here are less clear. Trikafta is associated with an increase in pregnancies, and cervical mucus quality in females on Trikafta is high. So people can use assisted reproductive technologies to conceive. And then, of course, contraception is an important means of preventing pregnancy if pregnancy is not the goal. And we still have a lot to do to understand the modulator effects on male and female fertility. Thank you all so much. I think we're going to all take questions together at the end. So we will move on.
Wow, thank you so much for that insightful presentation. Even after having a kiddo myself, I realize how little I know about male fertility. And thank you also for bringing up the dramatic shift in female fertility that has happened due to modulator therapy. which I think is why a lot of us are here. And thank you, Cindy, for even adding your personal experience in the chat. Remember, if Andrea sparked any questions in your mind, please write them in the chat, and we will try to get to them at the end of the session, as many as we can. As I mentioned, I am a mom with cystic fibrosis, and I have a 9-month-old baby boy, Brewer. As much as I talk about him all day long, he's adorable, you can see. I am here to talk about my journey of pregnancy, birth, and postpartum as someone with cystic fibrosis. Long before I found myself looking at a very positive pregnancy test, I always wanted to be a mother. But back in the 90s, CF was very much a pediatric disease and not an obstetric disease. At my sickest, when I spent most of my early 20s in and out of the hospital, almost being put on a lung transplant list, and so sick and underweight, I even lost my own period, I truly had to find my own why. Being a mom felt so far away, but I needed to figure out why I was fighting so hard, why I was doing all of my medications each day, why I was enduring IV treatment after IV treatment and endless hospitalizations. My why became pretty clear, and it was to be a mom. Well, clearly it wasn't time wasted. To maintain my health, I was drawn to being a yoga teacher and teach yoga to those with and without CF, and eventually became a studio owner myself. This commitment to my physical health and help from Trikafta allowed me to have a pregnancy where I did not need any additional intervention or treatment because of my CF once. So after my husband and I got married, we made an appointment with my CF center, just as Andrea said, at Johns Hopkins to visit my CF center, as well as the maternal fetal medicine doctor, and talk about what my journey with CF and pregnancy may look like, given my lung function, my health, and my medical history. Both my CF team and the MFM were encouraging and had little worries about the potential of a pregnancy and birth with CF. There were discussions of medications that were safe for pregnancy and what if I needed IV antibiotics while pregnant. But regardless of what happened, my team reassured me that they'd be there to help me get through whatever may happen. This is a great time for me to mention that anything I share today is not medical advice or what every CF pregnancy looks like. This is simply my own experience. We had this conversation in August 2023, and thankfully, because just a few months later, in November, we found out we were surprisingly already expecting. August 2022, apologies. Looking back, it's easy to think of just the joy of being pregnant, but to be honest, it was pretty terrifying to find out I was pregnant as someone with CF. I'm very much a likes to be in control type of person, and having CF my whole life, I knew my body pretty well. I had my health under control, and after many years of turbulence, the list of what ifs that my brain quickly generated about pregnancy and CF once I saw the positive pregnancy test, despite already meeting with my doctors, was rather lengthy. As our pregnancy happened a little faster than we expected, my husband and I had only gotten a general CF screening done for him. So once we found out, we quickly got him the broad spectrum CF genetic sequencing panel. I would recommend doing this if you know kids might be a part of your plan, as it can be very expensive if it's not part of insurance. We were a bit shocked that Connor did not have a CF mutation, but instead an abnormality on his CF gene sequencing. But after speaking to my team, it was not a CF causing abnormality. He's just a little extra unique, even in his genes. Thankfully, I was able to stay on my pre-pregnancy medications, including Trikafta, throughout my pregnancy. I did change brands of enzymes for my pancreatic insufficiency out of suggestion from my pharmacist, but always check with your team on their recommendations. You may be realizing at this time, I live in the US Virgin Islands, and Johns Hopkins is indeed not a Caribbean hospital. You might be right. I had a wonderful local OBGYN as well as a local pulmonologist overseeing my care until I went to the States closer to my 3rd trimester. I was thankful that I had a fairly easy start to pregnancy with very little nausea. So I mainly focused on continuing to prioritize my treatments and staying as active as I could. This early time was so overwhelming because I was not only trying to take in more and more information about becoming a parent, labor and delivery, but also balancing CF life, maintaining my routine and health as well as I could, and really getting to understand a body that was seemingly changing every day. When I got pregnant, something shifted in me that never happened before, which I did want to share, because I think many times we just hear of the worst case scenarios. Before becoming pregnant, I tended to think of the worst case scenarios in terms of my health so that I could prepare myself. I could plan an admission if it was around the corner and align my actions to the best outcome for my health. In the end, I'm a warrior. I've been used to a CF body where, for lack of better terms, I'm always waiting for the other shoe to drop. But when I became pregnant, something shifted mentally that I will forever be grateful for. I had this overwhelming trust in my body that for the first time, my body's got this. My body was designed perfectly to create, grow, and birth a human. I genuinely can't explain the shift of perspective from viewing my body as a rock always teetering in between health and hospital into this almost surrender that my body's inner knowing knows exactly what it's doing. But before I get even more into my pregnancy and birth story, I will invite our next speaker to present the results of an ongoing study called MAYFLOWERS that Brewer and I were lucky enough to be a part of firsthand. This is also exciting because one of our registration questions was if there are any studies going on about the use of Trikafta during pregnancy and the effects on babies, which is exactly what our next speaker will be sharing about. Dr. Trimble is an adult pulmonologist at Oregon Health and Science University, and has been passionate about providing medical care for adults with cystic fibrosis for 10 years. Remember to continue to utilize the chat feature for any questions as he presents. So without further delay, here is Dr. Trimble.
Thank you, Chelsea. Really appreciate that. And I thank you, organizers, for the opportunity for sharing with you here at ResearchCon. If you can advance the slides, please. So as we've already heard from Dr. Roe, there's been a significant increase in pregnancies in people with CF over the last few years, especially since Trikafta became commercially available right before the COVID-19 pandemic. But even prior to then, for many of the reasons likely that she shared, there was already an increasing number of pregnancies seen in the US CF patient registry in the previous years. So that's led to a number of questions that people with CF have had, and those of us who work with people with CF have asked. How will pregnancy affect the health of someone with CF? And will taking Trikafta while pregnant affect the baby in any way? And will taking Trikafta affect a mother differently or a woman differently when she's pregnant compared to when she's not pregnant? And these are really important and really good questions that the CF community asked itself. Next slide, please. So that led to the development of a study that was really well planned, and I want to emphasize that essentially everything else that I'm going to share with you today is work from these two individuals here on the screen. Dr. Raksha Jain from University of Texas Southwestern and Dr. Jen Taylor-Kauser from National Jewish in Denver worked together and with support from the CF Foundation really developed a study called the MAYFLOWERS study, which integrates research to try to answer some of these questions along with the medical care that people are already getting at their local care center, to try to collect data on pregnancy, because that's not all very well captured in the CF patient registry. The registry, pregnancy wasn't real common when the registry data fields were being created, and it wasn't really designed in such a way to really answer a lot of the questions pertaining to pregnancy, timing, health of a baby, things like that just aren't being captured there. So a study needed to be designed to investigate not only what are the effects of modulator use are during pregnancy, but how does being pregnant affect the health of someone with CF? There had been some data looking at that, but it was quite old and likely outdated, as there had been a lot of new therapies, even besides CFTR modulators, that had come out since, over the last 25 years since this question had last been really assessed. Next question, or next slide, please. So real briefly, this is the study design for MAYFLOWERS. It's an observational study. So there's no experimentation, there's no randomization, no placebo, but it enrolls individuals after they know that they've become pregnant, and it involved 41 sites, CF care center sites across the country. And as of September, which is the data that I'm sharing with you thus far, because this study still is ongoing, about 285 mother-baby dyads, we call them, have enrolled. So if you're over 16, currently pregnant, and planning to continue with your pregnancy, you are eligible to participate in this study, which would follow you from whenever you became pregnant to delivery and up to about 2 years after then. Next slide. The main endpoint, the main thing the investigators are looking at is lung function in a woman after delivery compared to her pre-pregnancy lung function. Does being pregnant really affect the health of someone with CF now, especially in the era of modulators? Other things that are being looked at in the study is lung function in the longer term, 1 to 2 years out. Maybe infants are in a preschool or daycare and exposed to a lot of viruses and germs, bringing those home, getting sick. Weight, number of exacerbations, and then other things, pregnancy complications, gestational diabetes, etc. Next slide. There are also 2 other sub-studies that I'll look into this, but I'm going to mention this because these are ongoing. And I saw Dr. Taylor Kauser and Dr. Jane earlier last week, and they really are hoping that if there are people who become pregnant and their care centers participating, that they would be willing to enroll in these particular sub-studies. This is to look at continuous glucose monitoring even in women who don't have CF related diabetes, to investigate if there's glycemic or changes in blood sugar associated with pregnancy. Next slide. And the other sub-study is ETI or Trikafta, pharmacokinetics or PK. It's looking at how much drug would a fetus be exposed to during pregnancy, or would a baby who's being breastfed be exposed to following following delivery, as these are really important questions that we'll hear from that will be important when we hear from Dr. Fortner later. Next slide. So this is enrollment. This study is enrolled really well, with the exception of, like I said, the CGM and the drug levels. The PK studies has been a little slower to enroll. Next slide. This is a demographic slide that showed the sort of what the group of people participating in the study look like, which tend to reflect largely the registry. Next slide. And for many people, this was they were able to spontaneously conceive, like we heard about from Dr. Roe. Next slide. And these are some interim results here. So largely they showed that lung function remained fairly stable, but did seem to decrease slightly just after birth. Next slide. Weight increased as would be expected during pregnancy, but returned to pre-pregnancy levels largely. Next slide. And these are symptoms of how short of breath people feel. And you can see from this box plot here that people tend to feel more short of breath as they became more pregnant. But this is also seen in people who don't have CF. Next slide. Mental health scores from the PHQ-8, which is a measure of depression scores, and GAD-7 was a measure of anxiety scores, which were pretty stable. Next slide. And these are sort of the outcomes. There were 140 deliveries that were reported on here, with about 94% recorded using modulator during their pregnancy. Next slide. Infants were generally, I'm sorry, in the previous slide, we should go back if that's possible. I'm sorry, this is important to point out. The number of miscarriages here was quite low. This is there were 4.3% spontaneous abortion or miscarriage, and around 3% had induced abortion, which is lower than is seen in the general population. But I should point out that these people tended to enroll in this study after they knew they were pregnant and were maybe interested in a study. So there's quite a bit of what we call selection bias here. But by and large, when people had told their care team, hey, I'm pregnant and yes, I'd be interested in this study, the live birth rates were very good. Next slide. And next slide again, please. And complications seen on the whole, C-section rates maybe slightly higher than seen in normal, but still kind of in range. There were some extended hospitalizations for the infant with some extended NICU hospitalizations. This is not really well understood, and this study is still ongoing, so still hard to draw any conclusions if this is significant. We're also still getting information from these cases. Preterm labor rates also sort of within range. Next slide. So the main conclusions we can draw from these preliminary results, and again, I want to report this is still ongoing, the study, that the majority of people with CF are continuing their modulators for all or part of their pregnancy. We do encourage people to have that conversation with their care team to discuss risks and benefits. But at this time, it's a little too early to draw definite conclusions about maternal or infant outcomes. But these results are helpful and to help guide care teams in decision making. There seems to be some trends that lung function is maintained during pregnancy, but maybe a little decreased in those early postpartum months. Weight is increases appropriately and is maintained following birth. And then the other scores that we talked about. Next slide. And Chelsea, I think we're ready for you again.
It's me. Thank you so much for that presentation, Dr. Trimble. As someone who contributed to the MAYFLOWERS study and actually just submitted my 9-month postpartum information, I know from personal experience, but it's always great to see all of the other participants' data compiled so that we can see how it is evaluated as a whole. I know I was pleasantly surprised and shocked that there was a consistency in the FEV1 data throughout pregnancy and postpartum. I know as someone who just had a baby, I was thankful that we were able to share this with the CF community so we can make more informed and educated choices about our reproductive health. I wish I'd seen this study before I got pregnant. Would have put a lot of those questions to bed. But to answer a question in the chat about my enzymes that I switched off of during pregnancy, I switched from Zenpep to pancrease. Plenty of people stayed on Zenpep that I know of. That was just what was recommended to me, like I said. Just sharing my own experience. But speaking about FEV1, I too am glad to say that my lung function stayed consistent without any dips throughout pregnancy and postpartum, which was my main worry as I hover around 55% these days, and I really try and keep track of every percentage. I had a few CF related and non-CF related events throughout my pregnancy, including one bout of kidney stones, which landed me in the hospital for a few fun-filled evenings, a few instances of hemoptysis or coughing up blood, which I ordinarily never have, a bout of COVID, and a diagnosis of gestational diabetes at 28 weeks that thankfully with a continuous glucose monitor was managed very easily with diet and no need for insulin or medications. So all in all, my pregnancy was rather smooth sailing, despite the laundry list of worries that I first had when I first became pregnant. The mental side of the later stages of pregnancy was a challenge, trying to imagine my life and how it would evolve from a CF health-centered patient life and morph into a mom life while still prioritizing my own needs. My husband and I talked extensively and continually about my needs, his needs, and how we can work as a family unit to continue to keep me and baby healthy. We did travel from the Virgin Islands to the States at 34 weeks and awaited Brewer's arrival. In a non-CF related item, Brewer was actually breech or booty down instead of head down from 20 weeks on. This left us with a decision to schedule a C-section or to manually try and flip him to head down in a procedure called an external cephalic version or ECV so that I could give birth naturally. At 37 weeks, we went into the hospital. I received an epidural in case the ECV attempt ended in emergency C-section. And thankfully, what we deemed the great flip was successful on the first try, and baby Brewer was already become naturally on his own time. One of the most incredible experiences in this was after the grape flip, a doctor who had helped perform it came in full PPE, which I had noticed to begin with, and came and shared with me that she was an OBGYN resident and had CF herself, and how special she felt having helped someone with CF who was pregnant. And that entire experience, ending it up with that conversation, really just showed how serendipitous this whole experience was and reminded me of how we all truly are in this fight together. As one can expect, my belly grew, and I did get shortness of breath and was prescribed a steroid inhaler, which made a world of difference. I was ready to adjust my treatment regimen if needed as my belly continued to grow. But to my surprise, I was able to use my vest right up until the end, until I gave birth. Given my overall health in my third trimester, my MFM was very supportive of my desire to have as natural and with as little medical intervention of a birth as possible. This allowed me to push past when she would normally induce CF patients, and it still makes me giggle thinking about the amount of times she said, "Well, I can't believe I'm saying this to a CF patient, but let's just keep waiting." We continued to wait, and at 39.5 weeks, I had a membrane sweep to encourage labor along. In less than 24 hours, I woke up at 4:30 to contractions. I waited a few hours because I had actually been having false contractions for weeks. But finally, when I woke Connor up at 6 a.m., I said, "I think I need to do my treatments." To which he said, "It's 6 a.m., go back to sleep." Anyone who's been with a pregnant person knows the insomnia is real. But once I informed him that no, this was not just pregnancy insomnia, today was the day, he shot up out of bed and quickly began running around the house like I imagine many first-time dads do. I arrived at the hospital and was already 6 centimeters. By the time I got into a very busy delivery room, clearly July 26th was a very popular date. We didn't have to wait long. I did get an epidural, even though that wasn't quite part of my birth plan, but soon it was time to start pushing. This was honestly one of the most worrisome parts of birth as someone with CF. You see everywhere in movies and classes to hold your breath for a count of 10. And I doubted in the moment that I could even do that. I was very thankful my team was wonderful and worked with me to help me get my pushes effective without wearing me out. Like I said, though, I had a very speedy labor and delivery. From when I started to practice pushes until when Brewer was born was only 30 minutes. And when he did come, he came out in one push head to toe. I still wish I had a camera to capture Connor's reaction on him coming out. It was so fast that the only people in the room were my nurse, my doctor, and their trainees. Brewer Lee Stahl was born at 3:16 p.m. and weighed 6 pounds, 6 ounces, and was a perfectly happy baby boy with an APGAR score of 9. Baby boy did not have CF. I was eternally grateful that we were able to bask in that first golden hour with him on my chest and just take in the gravity of what just happened. Samples of Brewer's cord blood were taken for the MAYFLOWERS study, and overall, those first few moments are ones that I will genuinely cherish forever. I did have questions about breastfeeding and Trikafta, as well as the effects of my gestational diabetes that may have had on Brewer. I decided to breastfeed, and I'm still exclusively breastfeeding and pumping 9 months later, which could be an entire other discussion because we have had our trials and tribulations with breastfeeding, as many do. However, I'm happy to report that Brewer is passing all of his pediatric appointments with flying colors and meeting all of his developmental milestones. Now begins the hard part. I know. For 9 months, I thought creating a baby and birthing a baby was the hard part. Nope. Parenting is definitely the harder part, if you ask me. I will touch a bit on my postpartum and parenthood experience in a moment, but next you will hear from our last speaker, Dr. Christopher Fortner. He is a pediatric pulmonologist and associate professor of pediatric pulmonology at SUNY Upstate in Syracuse, New York. As you will learn, he has had the privilege of taking care of 2 of the youngest CF patients ever exposed to CFTR modulators, both born to mothers with CF who were on Trikafta during their pregnancies. And now, welcome Dr. Fortner.
Thanks, Chelsea. So next slide, please. I'm going to talk about when the unborn infant has CF and mom is on a modulator and the things that we are learning in real time So next slide, please. There are some developmental and newborn challenges to CF that we took to be typical for unborn or newborn children. We expect some level of pancreatic injury or pancreatic damage. In fact, that is part of an abnormal newborn screen as a blood marker for pancreatic injury. And this may even be severe enough to lead to pancreatic insufficiency, which means the babies would need to start taking enzyme replacement therapy, like Chelsea mentioned, taking Zenpep or pancrease. And there's also a risk for intestinal blockage, and this may even show up on a prenatal ultrasound as echogenic bowel or extra dilated or loopy or strange looking intestines. But after birth, this echogenic bowel can lead to what's called a meconium ileus, where in the first 24 hours, the newborns are not able to pass stool normally. Sometimes this is so severe, and it happens in 1 out of 5 children with CF. Sometimes it's so severe that it requires surgery or an enema to relieve the ileus or obstruction. The other thing that Dr. Roe mentioned early is the vas deferens structures typically do not develop for males, and that's the CBAVD condition. Next slide, please. So I say we took those things as typical until we met the first baby who has CF, but her mom also has CF, and mom took Trikafta for her own health the entire time. And next slide, please. And I'm going to walk through this newborn's, and now she's a almost 4-year-old, but her pancreatic story was pretty fascinating to me. I'm a lung doctor, but her pancreas with 2 F508del mutations, we fully expected that she would be pancreatic insufficient. In fact, before we got her first stool sample back, I started her on an enzyme replacement therapy, and she took it for about a week until her first fecal elastase returned at 500, which is normal. And on the graph, you see all the up and down lines. All that really tells me is fecal elastase values fluctuate, and I don't have an explanation for why, but all of hers fluctuated in the normal range. And along the bottom, there's sort of a timeline. We've got the in utero exposure, so 9 months of Trikafta exposure before she was born. And then mom was able to breastfeed exclusively for a year, either directly or freezing and pumping and freezing. And in that first year, the baby maintained normal pancreatic function, did never have to go back on enzyme replacement. And then there was a period between 12 and 21 months where she was off modulators, because at that time, the first available modulator for an F508del homozygous patient was Orkambi, and it was only approved down to 2 years old. It's now approved down to 1 year old, but she had this period of, wasn't old enough for Orkambi yet. And we were very worried that her pancreas wasn't going to do well during that. And it thankfully did well without intervention. She was able to start Orkambi once it was approved down to 1 year old. And her pancreas got through that portion. And then, these days I would have her on Trikafta as soon as she was eligible, which is 2 years old. But at the time, it was only approved down to 6 years old. So she was really kind to us by doing exceptionally well without having us to go off-label. Next slide, please. We also watched her sweat chlorides, and from the beginning, they were lower than expected. Normally, you'd expect something over 100 for somebody with homozygous F508del CF, but hers were only in the 60s. And even when she was breastfeeding and not taking any modulator other than what might pass through the breast milk, her sweat chloride remained just above 60. And as the modulator wore off and she wasn't getting any through the breast milk any longer, her sweat chloride jumped up to above 100. Later, when she started Orkambi, she saw a drop in sweat chloride. And then when she was able to switch to Trikafta, she saw a further drop. And now her sweat chlorides are in the borderline range, closer to normal. They're just above 30. So they're closer to normal than they are to CF levels of CFTR dysfunction. Next slide, please. So we're in new territory. We've got a normal fecal elastase after birth. We've learned that the IRT measurement, which is part of newborn screening, may be normal, which can lead to a false negative. Now, the genetics can still be tested, and that's how we found she had 2 F508del mutations. But we've got lower than expected sweat chloride. And in patient 3, I didn't talk about him too much, but he was the second one born to our center, not related to the first patient, but he has vas deferens. And we know that because I sent him to a pediatric urologist at 8 weeks old, and they were able to palpate them. And the reason I sent him to an expert is, again, I'm a lung doctor. If I didn't feel a palpable vas, I wasn't going to say, oh, there's definitely not one. But sending him to an expert who does this every day for a living, when that doctor said, yes, there is definitely vas deferens structures, he felt one on the right side, and then a few weeks later, he was able to feel the one on the left as well. So this triangle design on the right is an older picture, but it kind of has these features of CF that develop with a more severe molecular phenotype, which that just means how much CFTR dysfunction is there. And F508del is sort of the classic CF, or should be, without modulators to help it function better. You know, it typically has a very positive sweat test and all the usual features: male infertility, CBAVD, pancreatic insufficiency. But we've got now 2 kids at my center and 2 others around the country that I know of now who are essentially at the bottom of the pyramid with no features of CF, but a genotype that says they should have serious CF consequences. So delighted to see that we're maybe treating them before they're born and seeing benefit. Next slide, please. So what about when the unborn infant has CF but mom does not? There have been some cases of expecting mothers who have been willing to take Trikafta to benefit the developing fetus. And now we're getting pretty off label. So I want to go to the next slide and just state for the record, the CF Foundation doesn't have any official guidance regarding the off-label use of CFTR modulators during pregnancy, either in people with or without CF. And we're continuing to learn more about the effects of modulators, but there's not any published clinical studies. There's case reports like mine and others, but no MAYFLOWERS trial equivalent yet. So we recommend that anyone who's exploring off-label use in any way, shape, or form consult with their CF provider, and in this case specifically, also consult with your maternal fetal medicine specialists. Next slide. So the number of cases of unborn infants whose moms are carriers, but the baby has CF, it's growing around the world. These are some of the countries that I know of. There's probably others by now because I made this slide last fall, but this is happening more and more often. Next slide. We're learning or doing our best to learn from each of these experiences. There are 16 cases that I know of so far around the world of carrier mom CF fetus. Many of these moms had challenges obtaining Trikafta. They either had to find a source who wasn't using all of theirs, or had to get insurance approval to treat the fetus who has CF. So it's been a challenge to get Trikafta, even when these moms want to do it. And for all of them, they had 2 confirmed CF mutations in the fetus, including a Trikafta responsive mutation. The range of start dates have been as young as 23 weeks of gestation on up to 32 weeks of gestation. The shortest that I'm aware of was only exposed for about 5 days. And for most of these infants, there were ultrasound findings that were concerning for meconium ileus before moms started on Trikafta. So 14 of them had that echogenic bowel. But of those 14, only 2 of them had clinical meconium ileus after they were born. And those 2 who had meconium ileus did not need surgery, which is still a huge benefit. Next, please. So what about once the infants are born? We expect that the level of CFTR function will decrease without modulators. What we don't know is if the baby has a vas deferens, even if it's present, is it going to obstruct? And that's a question I may not be able to answer for you for another 16 to 18 years, because these first babies are nowhere near puberty at this point. We definitely know there's a risk of withdrawal pancreatitis. While their pancreas is working when they're born, we've first suspected this based on a ferret model of CF, but we also observed it in all 3 of the earliest patients. They had elevated serum lipases, or sort of signs of pancreatitis, whether they were symptomatic or not. The second patient that I didn't talk too much about him, but he had to stop. His mom was not able to breastfeed, so he withdrew from a Trikafta pretty abruptly and ended up with symptomatic pancreatitis and a loss of pancreatic function, which thankfully was able to improve once he got back on Trikafta when he was older. Next slide, please. So how do we best take care of these infants? There's the strictly on-label approach, which, like I said, that's what patient 1 let us do. But we're limited. We may not be able to start Orkambi, or if they don't have 2 F508del mutations, we might not be able to get any modulator until they're 24 months old. We do think that if mom's on Trikafta and the infant's breastfed, some is passing through the breast milk. It's been measured. Dr. Trimble has a study that shows at least some of the Trikafta is detectable in breast milk, but the concentration seems pretty low. Our sweat results suggest that there's definitely benefit to that low concentration of Trikafta, but the Mayflower study is going to help us know more about that, especially for the infants who are participating in the pharmacokinetic portion. There is also weight-based dosing, which is off-label, and one of the areas that I had to get into out of necessity, because through none of my doing, I got to take care of this young boy who has vas deferens. And his parents' first question to me when he was born was, how do we keep him on it? That was Dad's first question. And I had no idea. And so I started thinking about it very, very seriously, especially knowing that mom's breast milk hadn't come in yet. So he was at risk not only of vas obstruction, but pancreatic dysfunction as well. So we've been able to calculate the doses based on infant weights and the ivacaftor component. And the reason we use the ivacaftor component is the ratio between the 3 ingredients in Trikafta is always the same. Ivacaftor is one of the 3 ingredients. But if you look at that ingredient alone, for certain people, that's approved down to 1 month old if they have kalydeco-responsive mutations. So we've got approved doses on that ingredient down to 1 month old, and we used those to extrapolate what would be good doses, if we keep the ratio of elexacaftor, tezacaftor, ivacaftor, the 3 ingredients of Trikafta, keep that the same and dose it based on the ivacaftor component. Even if we've got the math right, the question is when to start. Do you start right away, or do you start only if CF problems are observed? And these are the kind of discussions that you have to have with your care team. Another option that has been done was to taper off of Trikafta. There was a mom on the west coast of the US who, she was a carrier, and the Trikafta was affecting her postpartum depression and anxiety pretty significantly. And she was only taking the Trikafta for the benefit of the newborn. She herself doesn't have CF, but she was passing it on through the breast milk. And for that child, they chose to taper off the Trikafta for mom's mental health and also to avoid pancreatitis. And they were able to successfully do that. And he should be turning 2 right about any time now. So I don't believe he's on weight-based dosing. Next slide, please. So we're going to try to do a word cloud activity in the next few minutes. I want to know what excites you about the new era of reproduction for those with CF. And how do you enter those? Over on the side by this chat screen, there should be a thing that says Mentimeter. And if you click on that, you can enter a word or 2, or I think there's 3 levels that you can enter words. The responses are going to be anonymous, and the word cloud's going to generate, while we're watching. At least I hope that's how it works. Next slide, please, while you're thinking about what you're going to put in. And please don't limit yourself to the stuff I've talked about. You may be excited that you're going to take up yoga because Chelsea's such an inspiration. So in terms of parenthood and CF, Chelsea has already started speaking to this, and I think she's going to talk a little bit more about it. But in my mind, parents are superheroes, but every hero has their kryptonite. Infants, newborns, they have nearly constant needs, and you need to have a plan. Who is going to help the parents meet their own needs while the child's needs are being met as well? When is mom going to have a chance to eat, drink, or sleep? When is dad going to have a chance to eat, drink, or sleep? Then you add in CF for the parent, and you have to account for, if they're doing treatments to maintain their own health, who's got baby duty during that time? So I'm sure you've probably heard the African proverb that it takes a village to raise a child. I think with CF in the mix, it's even more true. We need a village to raise the child, because what if a parent gets sick, or what if the child gets sick and brings home germs from daycare? So next slide, please. Hopefully this is the word cloud. And it is starting to populate. People are encouraged about the possibilities and healthy babies and the presence of VAS and healthy pregnancies, and all of these things are just, I agree, exciting to me, and I'm glad the audience is excited about them as well. I'm going to let this continue to populate for another, I don't know, let's say 20 seconds or so as it continues to grow. Oh wow, the cloud is truly boiling like a thundercloud. That's fantastic. All right. So thank you everyone for contributing to that. I'm glad, if we can go to the next slide. On there, I saw HOPE, but I also saw specifically HOPeCF, and I'm glad someone put that. There's a study going on for health outcomes of parents with CF. Tracy Kazmersky in Pittsburgh is the lead investigator on this, and it's aiming to put more details versus just, case report or what MAYFLOWERS is studying. They're looking at people with CF who have children compared to people with CF who do not have children. And that's AIM 1. It's sort of a longitudinal study using past data from the CF registry and a parent survey. And that one's not quite done. They're still looking for about 300 participants. AIM 2 is going to start this summer. And it's a prospective cohort study where, the exposure is parenthood. So for people with CF who become parents, it wants to look at their lung function, but also depression, level of parental responsibility and stress, and their modulator use. So that should be opening up this summer. And this, I believe, would be an opportunity for people who want to help us learn more about not just what we're learning in the Mayflower study, but about that early period of being a parent with CF. So I'm going to toss back to Chelsea now to finish things up.
He's my own kid. He's just so cute when I see the pictures. But thank you so much for that wonderful presentation, Dr. Fortner. It is so miraculous that there are kiddos being born with CF that are passing the newborn screening and with pancreatic sufficiency due to Trikafta during pregnancy. I can only imagine what things like this mean for the future of CF kiddos. Like Dr. Fortner said, I think, as any parent can attest, CF or not, parenting is hard. Probably the hardest job that you're ever going to do in your life. I know it is harder than anything I have ever done. That is the reason I'm so happy that Chris mentioned the Hope for CF study. Managing CF and being a mom certainly poses its challenges. But I try my best to prioritize my medications and treatments every day because I know that those are the things within my control that can positively affect my health and ensure that I can continue to have energy, stamina, and health to keep up with my little energizer bunny of a little one. It was really great once we became parents that my husband and I really looked at our life and we were able to figure out the best schedules and strategies to continue to prioritize my health, as well as contingency plans if I do end up with an exacerbation. Even as the responsibilities of parenthood became more and more, this ties into the fact that Dr. Fortner even brought up, that the support system that you have around you is so necessary, whether you are someone with CF or not. Our little man was extremely colicky for the first few months of life, and anyone who has been through that understands how tremendously difficult it can be, and especially on top of daily CF care. Thankfully, we were able to go spend a few weeks with my husband's family, and they greatly helped us adjust to the demands of parenthood, as well as providing support to keep me healthy. Remember that asking for help is not a weakness, but instead a strength. One of the cutest things about parenthood that I do want to share is after 9 months of doing my best twice daily, even into the 9th month of my pregnancy, where I envisioned poor Brewer enduring a twice daily earthquake in his tiny belly home. When Brewer was born, one of the only things that we could do to get him to fall asleep instantly every time was me doing my treatments, and specifically my vest. It became a routine that every time I did my treatments, he would come lay with me, and at the end of treatments, every time, he would be fast asleep. There were even times that I slipped out of my vest and left it running and snuck away just to keep from waking him up. Now, crawling and trying to walk every day, that's a little harder, but now he sits with me and does it while I do my treatments, and he's gotten into the habit of grabbing a used nebulizer and putting it in his mouth, just like he sees moms do every day. I personally can't wait to watch him grow up and see me not just as a mom with cystic fibrosis, but instead a fighter, a boundary pusher, and someone who never gave up on our dreams despite the hurdles. And if you want to keep up with my journey of motherhood and CF, you can always follow me on Instagram at salty_yogi, where I share all the Brewer pictures if you would like any more. I know we are almost at our scheduled end time, but we do want to have about 10 minutes of Q&A. So now is the time that you get to have all of the questions that you have been asking answered. So thank you for sending in the amazing questions throughout the session, as well as when you registered. And although we'd like to get to all of them, we'll try to get to as many as we can. So please upvote those questions that you'd like us to prioritize. So first, I'd like to have us answer one of the questions that was put in during the registrations. And this is actually going to bounce right back to Dr. Fortner. If you could answer a question we received that asks whether we think someday modulator therapy will be typical prenatal treatment for babies with CF.
It's a great question, and I think it's absolutely, yeah. It looks cutting edge and a little radical right now, but I do believe it's going to become what happens as soon as you know that a fetus has 2 CF mutations. If one of those is Trikafta responsive, I think it's going to become standard of care to start Trikafta for the sake of the fetus, as long as the mom can tolerate it.
I think that is definitely something that I think we can look forward to seeing more studies on as we can present maybe in next year's ResearchCon. Who knows? Come back to see. I see there was an upvote a lot about the NICU rates. I think maybe Dr. Trimble will be able to note on that if the NICU rates discussed are higher than average population.
Yeah, so in the MAYFLOWERS results, about 20% of infants had a NICU stay, which is higher than observed in the general population. That is something that we are looking into. I'm afraid it's still too premature to know why, and data is still being collected to understand exactly what those NICU stays represent, whether it was just related to being preterm or what.
That definitely all makes sense. And it definitely makes more sense why they were definitely a little more apprehensive when I asked to leave after 24 hours of birth. Like, what? Like, he's fine now. Look at him. He's so cute. Well, thank you for noting that question on our NICU stays. We seem to have a lot of interest on that one. I think maybe Andrea, we have a question about research exploring the resources utilizing during pregnancy, such as doulas or midwives, to improve the outcomes of pregnant and postpartum women with CF. Is there anything in this area?
I'm not aware of any research specifically on doulas for pregnant people with CF, but in general, the use of doulas is very encouraged and has actually been shown to improve obstetric outcomes. So if you can get someone in your corner during the birth process, which is sometimes not easy, it is great to have somebody who kind of knows what your goals are, knows you, and can also talk with the obstetric team in the hospital. So nothing specific to CF that I'm aware of, but a good thing overall.
Thank you so much. I definitely looked into plenty of that research myself when I was pregnant. So it's good to hear from an obstetric point of view, the similar views on doulas and their benefit. Let's see, let's do one more Mayflower before we pop back over to Dr. Fortner. Looks like we're curious whether the Mayflower results have been cross-referenced yet with pre-modulator pregnancy data. For instance, are the FEV ones or weights better maintained pre-modulator pregnancies, and are premature births less common, similar with NICU stays? So essentially pre-pregnancy or pre-modulator versus modulator.
Yeah, it's a great question. It's a little complicated to answer, but the short answer is yes. The Mayflower study did cross-reference with the CFF patient registry for individuals who enrolled in the study. They were able to go back and look at data from the registry prior to enrolling in the study. But because the CFF patient registry didn't really have information on pregnancy prior to Mayflowers, there wasn't a good way to answer that question. Hey, how has ETI or Trikafta or modulators in general changed pregnancy outcomes? And this was an area why, at least for my part, and I know others on this call and in this session are really excited. The CF Foundation and those in the CF space are expanding beyond just pulmonary studies and actually investing research time, dollars into reproductive health, because this was something that was not well studied or well understood prior to a few years ago. So we don't really have great data on what those outcomes of pregnancies were prior to modulators. And what Mayflowers can do is only cross-reference within an individual.
I think that's a good question. I'm trying to find it, but I do vaguely remember it. But there was a question, I believe, more specifically to Andrea, where is there going to be a more subspecialty of obstetric care or urology for men, obviously for reproduction with CF?
Yeah, that's a great question. And I love it because I think I can say for sure that the answer is yes. There is, I think, with all of the growing interest in reproductive health in CF these days, there's sort of an increasing recognition of the need for specialists that are associated with CF centers. And so I think CF centers are starting to make friends with OBGYN and urology colleagues. And actually, I'm a part of a program that is sponsored by the CF Foundation called Envision CF, which was actually started originally to kind of bring in endocrinologists into the CF center care fold and kind of expose endocrinologists to CF, educate, get people involved in research for CF-related diabetes, et cetera. And then I was invited to join this group as one of the first reproductive health specialists. And now I'm roping in even more people. So we've got a couple of OBGYNs, a couple of reproductive urologists. And so we're spreading the news. So I definitely think associated reproductive health specialists are on the rise.
That is definitely exciting news for me. I saw an MFM as well as a local OBGYN while I was in the Caribbean. And I definitely felt like I got the look of a deer in headlights a few times, but thankfully the MFM was much more relative to cystic fibrosis. So I'm glad to see more and more people will be exposed to that as the rise of pregnancies. We have a question for Dr. Fortner. It looks like we're asking, has there been any evidence of, I will butcher this word, echogenic bowel going away through the use of Trikafta during pregnancy for a non-CF mother, but a CF baby?
So that's a great question. That's actually the case report from Dr. St. Petery. That's actually what happened in their case. The baby was exposed to Trikafta for about 4 weeks. Their ultrasound, like the day before she was born, showed resolution of the echogenic bowel. So absolutely yes. And it's not just that case report. I'm kind of in touch with all the other 15 cases like that around the world. And it's pretty typical that the echogenic bowel resolves as long as you get enough time on the Trikafta.
That's amazing. And while we have you, Dr. Fortner, we had a question of how the vas deferens development is tested for preborn, born, or newborn babies. Is it just that you can test after birth? And how does that go?
So Dr. Roe mentioned that it can be seen on a prenatal ultrasound, but it looks obstructed in the third trimester in CF. I don't think we've looked for, boys like the ones that I know who had Trikafta the entire pregnancy or the entire gestation period. After they're born, I'm still waiting for the day where we can get an MRI or an ultrasound or something. I'm in constant conversation with my radiology colleagues and my urology friends to try to figure out, how do we image this? And the answer to how do we know if it works, that won't be answered until after puberty. But we would love to know, for the parents' curiosity, like, is this structure there? So we can, advise them and advise the teenager later on, hey, look, you might not be as sterile as you expect. So use some other contraceptive methods.
I've definitely heard of some adults, male adults, who are like, no one ever told me I couldn't have babies. I prevented this for so long. So it's interesting. We'll have the other side of the coin. I have a question. I'm not sure it will be for Dr. Trimble or Dr. Roe, but is there a goal FEV1 to consider being healthy before conception and during pregnancy while taking Trikafta? So is there a bar of ideal FEV1?
Yeah, I can maybe speak to that. So the short answer is no, there's not a number that's in any sort of guideline, and I cannot stress enough how much how much more there is to health besides FEV1, and I would strongly recommend being in conversation with your care team. For my part, as a practicing CF pulmonologist, there are patients who I know and love who have lung function that's relatively low, that I've supported through their pregnancy, and others whose lung function is a little higher, but yet who I would be quite concerned medically about their pregnancy, just because of other factors: disease stability, weight, other complications, a whole host of things that can make a pregnancy higher risk. So talk to your care team.
Completely. Definitely. Like I said, I even, before we got pregnant, sat down with my care team and asked a litany of questions and still had more, but it's always your care team knows your case the best in your own health journey. While we have you, Dr. Trimble, there's a study referring to freezing and thawing breast milk that increases the milk's fat globule size, which negatively affects the nutrients digestion in infants.
Yes, maybe I'm not quite understanding. Is the question is that going to hurt by freezing and thawing breast milk? Is that likely to hurt the nutritional? I may actually punt that
I
over to
believe
Dr.
that is the general question of
Yeah, I
the
may punt that over to
nutritional
Dr.
aspect.
Fortner. I don't treat patients who eat breast milk.
I
I'm an
mean,
adult
who knows what you're
pulmonologist.
doing yourself? But it was added at you, so
Yeah.
we will
Okay.
toss
No,
the
I
buck right
appreciate
over
that.
to
I
Dr.
will
Fortner.
punt that to Dr. Fortner.
So yeah, with this was about the freezing and the changes in breast milk after freezing.
Yes, the
So,
nutritional changes.
yeah, I hope that's going to be studied more, because the moms I know, even the ones who are able to breastfeed, it's not like they can always stop what they're doing. Most of them will pump at night or pump at work, and storing the breast milk. For my first patient, her final month on breast milk was all frozen breast milk, because she weaned herself at 11 months. She's like, I'm done with this. So we didn't see any clinical changes. She was, again, not needing enzymes, still growing well, not having any symptoms, but she was probably atypical because she had a totally functional pancreas. And if we're just doing breast milk for nutrition, I would say fresh is probably best, but that's not to say freezing it makes it worse than using a powdered formula or something like that.
Thank you for speaking on that. I definitely can attest that my little one gets very distracted. So sometimes freezing is what has to happen when you have a little baby going, ooh, ooh, ooh. Like, no, come back. But thank you for speaking to that. I know we have a question that was reposted, so thank you so much for that, James. The question is, if it is possible that the genetic modulator drugs help correct the CFTR mutation that could also improve sperm quality for CF males?
Yeah. I can maybe answer that question, or at least as best we can know. So there's sort of two different possibilities here that you could be referring to. One is, are the CFTR modulators, is taking Trikafta likely to improve the sperm quality in males? For ejaculated sperm, no, I'm afraid it's not going to, because there's anatomic changes that are present at birth. That's not going to change. But maybe what the question is asking, and that's a really good one, is what about aspirated sperm? Like the data that Dr. Roe showed, that even with surgically aspirated sperm, the quality is relatively low. And could it be that taking Trikafta could improve that? Those data that she showed were from males who prior to Trikafta, that does not reflect modulator treatment. And that question remains to be seen. There are several of us, as many of you may know, Dr. Roe and I and many others are part of a working group within the CFF Therapeutic Development Network to study sexual and reproductive health. And this has been an area that we've been working on, applying a grant for, to study exactly that question. What is sperm quality, and what's the best method for sperm extraction among men with CF? That remains an open question as well, and tracking outcomes with that at a multi-center level. So stay tuned. I'm afraid that's likely to take several years, but that's absolutely something that we are trying to look forward to answer. The other part is would potential gene therapies be not just modulators, but actually changing the gene, kind of the ultimate cure? And I think similar to modulators, even if you're an adult with CF, if we had, a way to make CRISPR-Cas9 work and make all your cells work and have your CF go away, I'm afraid those anatomic structures are the way they are. They're not going to change. However, it's very possible that we may believe that the testicular function may improve enough for aspirated sperm to be more on par with those that are seen in men who don't have CF. Well,
thank you so much for elaborating on that. We have two more questions that we have floating around. I did want to ask whether it was to Dr. Roe or Dr. Trimble, even Dr. Fortner mentioned this with one of the mothers, that whether there is a component between Trikafta and postpartum depression or anxiety. Dr. Fortner did mention one mother going off of Trikafta with a little one that had CF through breast milk transfer. So is there any data or is this being looked into?
About how Trikafta is absorption during pregnancy?
Postpartum depression.
Oh, sorry.
Its effects or anxiety.
Maybe I'll answer that if I could jump in. I think that is part of aim 2 of the HOPeCF study.
Yeah, absolutely.
To get a better,
love that.
Like get some numbers. Because right now all we've got are stories, but we're working on the research to give numbers.
I love that. We will definitely keep an eye on that HOPeCF. Again, maybe we'll all come back next year at ResearchCon and be able to hear a little bit more about it. I know I will sign up to contribute. But it looks like we may have one final question. This is for, I believe, Dr. Roe, or anyone who'd like to jump in. How might pregnancy change the way Trikafta is absorbed? How may maternal outcomes vary by mutation? Anyone?
Yeah, Dr. Rose, if it's okay, I may chime in here. This is absolutely part of the pharmacokinetics part of the MAYFLOWERS, which unfortunately we don't have data yet on the people, including you, Chelsea, who've contributed their specimens. They're actually sitting in a freezer waiting to be processed at the University of North Carolina in Chapel Hill. So they're going to be processed in batch, and they haven't been run yet. So but there is a little bit of some data that I have actually and Dr. Fortner helped with this some with his first case and measuring levels in women with CF drug levels during pregnancy. And we don't nearly have enough, I will say. There does seem to be, just from a very few number of women who had drug levels on modulators, that there does seem to be a change right at the time of birth, related to probably fluids shifts during delivery, but overall during pregnancy, I'm afraid we can't really say, and not nearly enough to be able to say anything about genotype. We wouldn't expect there to be significant changes in drug absorption, maybe in the way it affects cell types, especially those that are hormone sensitive.
Well, thank you for that answer, Dr. Trimble. I know there is one final question of if there's a list of resources to help those trying to build a family. And that actually is all available after the session. Like I said, the session is recorded. You can also find the slides as well as any resource material at the end of our session. And again, that recording will be emailed to us. But we are over time. Thank you all so much for taking the time from our clinicians. And this concludes our session today about the effects of modulator therapy on pregnancy and reproductive health. So thank you again, everyone, for your participation and your great questions. Thank you, Dr. Trimble, Dr. Roe, and Dr. Fortner. And before you go, please, to our audience, to fill out that satisfaction poll, which is right under the poll tab on the right side of your screen next to the session chat. Like I said, there are many wonderful resources related to this discussion, including slides, in the resource documents found on the reception page. Please spend some time exploring the resources and downloading anything you want to keep to be sure you can enjoy it. And be sure to check out the social lounges that are still going on to connect with old friends or make new ones. So thank you all for being such an engaging audience. And like I said, special thank you to our amazing clinicians for taking the time out of their busy schedules, even Dr. Trimble here in his scrubs, to be with us today.
Hello, everyone. My name is Cheyenne. I'm one of this year's co-chair along with Art and Cheyenne. And wow, what an amazing 2 days for our 2024 ResearchCon. I can't believe how quickly that past 2 nights just went by. I mean, we were so grateful you all were able to join us and learn the latest in research and clinical care and connect with each other throughout the whole shared experience. And if you missed the keynote or any one of those informational sessions, no worries. Those will be available to view on the replay room and later in the CF Foundation YouTube website.
Thank you, Cheyenne. Hello again. This is Art Brace. It was a fantastic experience to be a co-chair with ResearchCon with Cheyenne and Cheyenne. We'd also like to thank all the presenters and facilitators for all the sessions. A big thank you also goes out to Ali Stavroulakis and many members of the CFF staff for making the event a success. We hope you found topics and sessions that were educational and inspirational. Before you go, we would like to invite you all to the social lounges to close out the night, where you can continue to make connections with others in the CF community.
For sure. And to piggyback off of what Art just said, on behalf of ResearchCon Planning Committee, speakers, facilitators, and session advisors, we want to thank you all for being here with us for our 6th annual conference and making it such a success. We hope you enjoy learning and connecting together with us.
Yes, thank you so much for attending. A lot of exciting science was presented, and we couldn't be more ecstatic to see where the path to a cure goes from here. On behalf of my co-chairs and the CF Foundation, I sincerely hope we are leaving you with a sense of encouragement and optimism when it comes to the future of CF. However, I also want to leave you with a challenge. Use this newfound knowledge to take an active role in improving the CF patient experience. Join a clinical trial. Take the initiative to foster a better connection between your CF care team and the transplant center. Join the patient registry. Together, we have the power to greatly impact not just our lives, but the lives of the next generation of CF patients, until it's done for everyone. See you next year.